Great. Thank you very much for inviting me. I wanted to show you a picture of St Helier Hospital, but with the paint peeling off it, it didn't compare well with Griffiths University. Okay. What I'm going to try and do is to put everything together. I think we have a hypothesis as to what may be going on, and I think there is. We're entering a paradigm shift in how we look at chronic fatigue syndrome, and certainly in terms of immune dysfunction and autoimmunity. So I'm going to try and bring everything together. So in terms of working out what are the possible causes of CFS, I'm sure you've seen similar sort of information before. Is it due to a persistent viral infection? Is it due to an immune disturbance of unknown cause, disturbance of the hypothalamo-pituitary adrenal axis, primary muscle nerve disease, and all these other things mentioned here? But recognize that you could have a defect in one area that could involve another system. But let's go back one step and look at the big picture for the evidence of immune dysfunction. So what are the predisposing factors that might be used to work out what's going on with the immune system in CFS? Well, we know that fatigue is very common in those who have systemic connective tissue disorder, and the MRC has avoided grants on looking at fatigue in Sjogren's syndrome in particular. But as an immunologist, I see a lot of people with systemic lupus erythematosus, rheumatoid arthritis, and a whole variety of other things. And they all have fatigue as well. There are differences in the fatigue, however, and we could talk about this at a later stage. I also see a lot of people with primary immune deficiency and who have particularly antibody deficiency. And it's very interesting that this subgroup of people have very high incidence of symptoms that are compatible with chronic fatigue syndrome. The other thing is that people with joint hypermobility, and it was mentioned earlier, they too have a lot of fatigue, and we don't know why that's the case. In fact, amongst the patients that I see, probably about 10-15% will have a joint hypermobility syndrome, and possibly compatible with Ehlers-Danlos syndrome type 3. We all know that CFS, for some strange reason, affects women more than men, and the ratio may well be 5-1, something like that. But recognize also that the majority of connective tissue disorders, systemic autoimmune disorders, there is a high representation by females. In lupus, for instance, in the age group 13 to sort of 50, then it's 9 times more frequent. And same also with Sjogren's syndrome. We know there's a slight familial tendency for CFS to occur, but we've always attributed that to a shared environment. But that shared environment could include the number of infections that people get, the type of infections that they get. And there's also some evidence that certain personality traits will go on to develop CFS. The risk of CFS in Black Americans and American Indians is raised. Again, we don't know quite that's the case. And there are lots of other things here. We also recognize that fibromyalgia, irritable bowel syndrome, multiple chemical sensitivity is seen at high frequency in those with CFS. And this idea about previous mood disorders being more evident in people with CFS, and what is that due to? Why is that the case? And I'll try and address that issue in a second. And I think it relates to the adverse effect of stress on the immune system, and also when the immune system is suppressed, does that leave you susceptible to certain types of infection? Very quickly, I mean, CFS is related to a number of other disorders, and it's just very interesting how these occur. Irritable bowel syndrome, present in about 30% of people with CFS, fibromyalgia, systemic CTDs, connective tissue disorder, and joint hypermobility. Infections as triggering factors. I'm not going to labor the point here. A number of viral infections have been considered important, particularly Epstein-Barr virus. The evidence now is less clear. But in my opinion, EBV, while it may not be the cause of CFS, in the majority of patients, it does have proteins that can encourage the development of autoimmunity. And that's the sort of theme I'm going to return to again. You all know about bacterial infections, Salmonella, Brucella, and Coxiella, spirochetes, and Lyme disease, not particularly important in this country, protozoa, and a variety of fungi. But I don't think the fungal idea is very important. There's this other idea that immunizations may contribute to the development of CFS, and this condition of Asia has been appearing in the medical literature. That's autoinflammatory syndrome induced by adjuvants. And this may explain why some young people have developed CFS-type symptoms after certain vaccinations. And I guess you all know about the human papillomavirus vaccine and whether that might have contributed to the development of CFS. So what about other triggering factors? Life events we know are important. I'm going to try and script through this very, very quickly because I want to show you some of our data. Physical injuries can be important, and we've talked a little bit about environmental toxins in terms of organophosphates. And we know that several factors can adversely affect CFS, and sleep disturbance is one, poor, unrefreshing sleep. Well, how might that work? Well, we know that when sleep is not complete, when it doesn't go through all the 4 stages, then we know that there's a disruption of microglial function, and they can go on to release pro-inflammatory cytokines. Why do mood disorders like depression and anxiety contribute to making CFS symptoms worse? Well, I think it's related to stress, and again, I'm going to come back to that issue in a second. Why does overactivity contribute to worsening CFS symptoms? And I think the greatest difficulty is working out why that worsening of the fatigue is delayed, quite often the next day or the day after. Not only with physical overexertion, even more difficult to explain is why does mental overexertion lead to a worsening of the symptoms, often in a delayed manner? It's just very, very hard to explain, even in terms of immune dysfunction. But in terms of overactivity from a physical perspective, could it be that adenosine and ATP leaks out of the muscles, tissues, and acts on purinergic type 1 and type 2 receptors and disrupting the way that the mind works? We know that inactivity can be important, and intercurrent infection stress, we know that can be associated with the release of inflammatory cytokines, and the effect of vaccinations may be in a similar way. Now, stress is an area that we're very, very interested in because it has such a profound effect, not only on your psyche and the way you think, but it has a major adverse effect on the immune system. And we haven't quite worked out why that is, but we do know that stress by stimulation of the hypothalamic-pituitary adrenal axis contributes to the production of ACTH and prolactin, and it can also heighten the expression of certain types of neurotransmitters and their receptors. And I think that the impairment that stress causes on the immune system is very, very important, and I'll indicate why that's the case in a second. We know that raised cortisol leads to impaired inflammatory response and a shift to a particular type of immunity which tends to promote autoimmunity, but it also leads to a reduction in cellular immunity. And the cellular immunity is very, very important to counteract viral infections. And we know that patients with CFS have this impaired cortisol awakening response. And there's some papers out on that recently. What about stress and autoimmunity? We know that acute stress is associated with a raised predisposition to organ-specific and systemic autoimmune disease. I see a number of patients who have developed Graves' disease, and it's occurred at a time when they have been very, very stressed. And people with alopecia areata, which we know to be autoimmune related, they have lost their hair when they've been acutely stressed. So stress is very important in encouraging the development of autoimmunity. And we think it may be via disruption of the different T cell subsets. And in my opinion, the autoimmunity that occurs in CFS may well involve antibodies binding to one or more CNS receptors or neurotransmitters. I guess you've seen something like this before in terms of what stress does, in terms of the ability of stress to promote fatigue by the release of various sort of hormones, the disruption of the immune system. And when that immune system, particularly the cellular immune system, is disrupted, you have an increased chance of developing a reactivation of previously acquired viruses. And remember that Epstein-Barr virus is a herpes virus. Once you've got it forevermore. Same with CMV. But with the disruption of the cellular immune system, you're also more predisposed to new viral infections. And if you do acquire viral infections, it can disseminate more widely and cause more severe symptoms, which are more prolonged. And then when you start to worry something may be wrong, that has a further adverse effect on your cellular immune system, more viral symptoms. You can go around this circuit. But the main thing I want you to note is that although stress is important, it's important via the immune system and a disruption in the way that it works against viral and other sorts of pathogens, and the adverse effect of stress on preventing the immune system regulating itself. There's a lot written about CFS viruses in the immune system. We've written a review on this. We know that many patients with CFS report viral infections, and we know what sort of symptoms that they have in terms of their feverishness, their headaches, sore throats, glands, that sort of thing. But very few people with CFS actually report skin rashes, They do get colds much in the way as everybody else does, and cold sore, shingles, thrush, all those other sort of things that I look for in my patients with a recognized immune deficiency syndrome, we don't tend to see. So in people with CFS, I don't see many of them coming in with recurrent pneumonias or persistent sinusitis or meningitis. So this is a very subtle immune deficiency, immune dysregulation that's present here. And that's why it's been so difficult using some gross tools, like looking at the CD4 count, the CD8 count, looking at B cell numbers. That's why we haven't previously found any abnormality. We needed to look much more in much more detail. Now, if we look at the immune abnormalities in CFS, I'm sure you all recognize that there are papers which suggest that certain cytokines are increased, and then another one comes along and says, no, they're decreased. Certain subsets are increased or decreased, or they're not functioning properly. And there's a lot been written, and that's what's caused the confusion. And I think if we try to work out what is going wrong, then I think we need to come back to autoimmunity again, and I'll come on to this in a second. But in terms of the immune abnormalities that we do see in CFS, we don't recognize any major abnormality of the patient's serum immunoglobulin levels, in terms of their IgG subclasses. In terms of the routine tests of autoimmunity that we do, they tend to be negative in the vast majority. Some patients will have increased numbers of atypical lymphocytes, suggesting dysregulation or dysregulated control of viral infections and the orderly maturation of lymphocytes. But there is only very, very slight or little evidence of obvious inflammation in CFS because in the vast majority of patients, the CRP level is normal. However, if you look at large numbers of CFS patients compared with healthy people, there's a very slight increase in the pro-inflammatory cytokines, but not sufficient to actually cause a rise in the CRP level. And then, I'm not going to go through this in detail, but just to indicate that there are conflicting reports as to the levels of certain cytokines in CFS compared to healthy individuals. And the same really goes with the T-cell subsets. And in terms of T-cell activation status, it's been mentioned that the major finding that's been seen in a number of CFS reports on immune function relates to the NK cells and the reduction in function. Now, we too have looked at this. We haven't found a major reduction in NK cell numbers or their cytotoxicity. So it's very, very confusing. Now, why should this be? Why are some groups finding reduced levels of NK activity, normal levels, or increased level? Well, it may be because different groups are using different criteria. For all the work that I'm going to show you in a second, all our patients fulfill the Fucara, the Oxford, the Canadian criteria. And we think they're a very, very homogeneous group in terms of fulfilling these criteria and having what we think is a uniform illness. Some of the differences may be due to the different proportions of patients with mild, moderate, and severe chronic fatigue syndrome. We don't take into account the role of exercise, sleep, stress variables when we select the patients. It may be that in a particular group of individuals, the distance involved in traveling to get their blood test done, that might have influenced what time of the day the blood was taken. In the early work on HIV infection and looking at CD4 subsets, we found that blood taken very early in the morning revealed different subsets when compared to the evening. So there are lots of variables here. We also need to think about the different technologies that are being used to measure the cytokine levels. But what we have failed to look at, actually, is what happens to the receptors for the cytokines. When is it the case that in CFS, some of these receptors that bind the cytokines and which are involved in regulating T cells, could it be that some of these receptors become solubilized? They break free from the cell surface. In that case, they will bind to their respective cytokine, and that will cause a disruption in the measurements. Now, I also involved in investigating primary infertility, women who have preeclamptic toxemia and who have disturbed NK cell function. Now, in the past, the role of vascular endothelial growth factor in preeclamptic toxemia pregnancy, received a lot of attention. Some groups found that the level of the VEGF was elevated. Some said it was very, very low. And then it came to be discovered that the problem was that some of the antibodies used to measure the VEGF would attach to the VEGF at the part of the molecule which was away from the receptor. And the ones where they found that the level was normal the antibodies were being inhibited because they were attaching to the part that was binding to the receptor. So we need to think about what happens with the antibodies that we used, and could it be that there is exaggerated receptor solubilization? We also don't know whether, in the whole idea of autoimmunity in CFS, are patients actually generating antibodies against the cytokines? And is that what is causing problems with the immune system? I'll touch on that theme in a second. So when we look at our work, this is the demographics. And as you can see, we looked at 33 patients. The majority were in the moderate group, 2 severe. Comparable age and sex distribution. And as I said earlier, all the patients fulfilled the Fukuda and the Oxford and the Canadian criteria. All the people were negative for the routine antibodies in terms of smooth muscle, LKM, mitochondrial thyroperoxidase. None of them had gluten sensitivity. Serum immunoglobulins are normal in each of those, as indeed with the CRP and ESR. They were all seen at the same time of the day. And all patients were assessed in their serum for some of the very strange neurological antibodies that we look for in our patients with unusual neurological problems. So, in fact, all these patients were negative for antibodies to a variety of gangliosides. We then did a neuroblot looking for the unusual paraneoplastic autoantibodies, and again, they're all entirely negative. I'm not going to go through the B-cell gating strategy in detail. I'm going to come on to the results, but that, for people who really want to look at this in detail, we can share that later. And here are some of the results. Now, I'm going to show them graphically. What we found was that the transitional B cells were increased in people with CFS, and these are the B cells which are going from the bone marrow to the periphery. So they're increased. They're not fully functioning B cells. And in my opinion, they are B cells which have a greater tendency to produce low avidity antibodies, and they haven't undergone the checkpoints that normal B cells will undergo. The plasmablasts, which are the ones that will go on to form plasma cells, they were reduced again. The naive B cells, these are the ones that have the capability of producing autoantibodies, were increased. So the theme I'm going to come back to is really the possibility that CFS may well be due to a subtle autoimmunity, and that it is due, and we can show some evidence for this in terms of the sort of naive B cells, the ones that haven't undergone stringent checkpoint elimination if they have autoantibody capability forming. And then we looked at all the cytokines, and what these show is that the levels of interleukin-12, which is primarily involved in cellular immunity, fighting viral infections, but also to a certain degree in the correct maturation of the antibody responses, that is reduced. The IL-21 level, which is involved in germinal center formation within lymph nodes, that too is reduced, as is indeed is interleukin-27. So, and again, that's involved in the correct maturation of the B cells. So the theme that's emerging is that there is a subtle autoimmunity, that the B cells are, in general, not undergoing the correct checkpoint analysis, and that this is partly related to low levels of those cytokines that are involved in this process. But if we look at the T cells, again, I'm not going to go through the gating strategies. You can see here there are a number of T cell abnormalities that are present in our patients. But the end result, okay, is that there is abnormal interaction between the different T cell subsets and the B cells. And that what is happening is that the B cells are not being regulated properly, and that the more immature forms are emerging into the bloodstream, and it is these that have the ability to generate antibodies. Now, these aren't fully formed antibody responses. So these antibody responses are not against routine target antigens like your thyroperoxidase, like your adrenal antigen, nuclear antigens, that sort of thing. In my opinion, these are possibly IgM antibodies, and they are low avidity. Okay, so they haven't matured. Now, in people who have CFS of recent onset, okay, these antibody responses will be more frequent, but they'll be have a lesser capacity to bind to their target antigen. And at an early stage, I think they'll be more readily reversed. So that's why I think it's very important to make the diagnosis of CFS early to try and get some strategies in place. The longer you leave the illness to go on, the more likely it is that these antibody responses will become mature and they'll have high avidity antibodies are more difficult to reverse. So if we wanted to summarize immune abnormalities, so what I've hopefully shown very quickly is that there's impaired maturation of B cells. And we think that there are more with a tendency to autoimmunity. There's no evidence of autoimmunity to the presently recognized organ-specific and neuronal antigens. The cytokines that are involved in upregulating T cells against viral responses, they are impaired. But those antibodies, those cytokines, are also involved in B cell dysregulation, and they are reduced. There's also impaired T lymphocyte homing receptors, which can go into this in terms of the various molecules, so that you're having more T cells within the periphery, but they're not going to the site of action within the lymph nodes. And this absence of their sort of going to the lymph nodes to encourage proper B cell maturation may well be contributing to this state of autoimmunity. And there are increased numbers of T viral effector cells, again in the peripheral blood, but they're not going to the lymph nodes where they are needed to counteract viral infections. So, what do I think causes CFS? Well, I think that there's an initial B cell dysregulation, and that might be initiated by consecutive viral infections. And we hear very frequently, we're trying to learn from what we hear from our patients. We hear very frequently that the illness started after a series of viral infections. Now, disruption of the immune system is more likely to occur if those infections are evident at a time when the person is under a lot of stress, whether there's sleep disturbance, or there might be an injury or an operation or something. And again, I'll come back to this theme of stress being involved, because stress has such a profound impact. It's a subtle but a profound impact on the immune system. I suppose the best example of stress leading to immune impairment would be people who get cold sores every time they get stressed, or they get shingles. Yeah? So at a time when there is a lot of stress, the immune system is not working properly, it's not regulating itself. If you develop one or more viral infections, then it is likely that that virus will not be properly contained. It'll disseminate widely and cause greater mischief. Now, in some people, the B cells will, in time, start to produce autoantibodies, and I think they're going to be directed against it stands to reason, not going to be directed against conventional or routine antigens, but I think they're going to be directed against neural antigens in particular. And we need to home in onto the central nervous system. And one of the bits of work that we want to do is to look for antibodies targeting central nervous system areas, and particularly the hypothalamus. Now, these autoantibodies will contribute when they are directed against certain central nervous system areas to impaired arousal mechanisms, sleep dysregulation, autonomic dysfunction. And some of these autoantibodies may also target mitochondrial proteins, and removing these autoantibodies may reduce the symptoms. But I think what you also need to do, because we've heard that rituximab can be helpful, it wipes out the B cells, and the B cells are, of course, the ones that lead on to the plasma cells that produce the autoantibodies. But if, I'm returning to what I'm saying earlier, if there is impaired cellular immunity and you're not getting rid of the virus, you're not containing it, what you really need to do then is not only get rid of the abnormal B cells and allow fresh ones to come from your stem cells, okay, your pro-B cells, your pre-B cells, but you also need to try and reduce or eliminate the viruses that were originally causing the mischief. And remember, it may not be one virus, it may be more than one. And then we then have to come back and think about viruses like Epstein-Barr virus, which has several proteins which can stimulate the BCL2 proto-oncogene, which encourages the survival of a variety of B cells, even those that have autoantibody forming capability. So, in summary, I guess, I don't know if there's a note, okay. In summary, therefore, I think that CFS is a very, very complex disease, and that we need to think about the onset of the condition in terms of what sort of factors were evident, what was the state of the immune system when the person first became ill. And we hear this from our patients, that when they became ill, there was this stress, sleep disturbance, and everything going on, and then they had a series of viral infections. So I think that's what we need to focus on. And we need to think about autoimmunity. I think we are entering a sort of paradigm shift in the understanding of CFS, because I think that it will very likely be due to immune impairment, very subtle, leading to autoimmunity and producing antibodies that target one or more central nervous system proteins. So I'm going to leave it at that and take some questions.
Excellent. Very good. Very good. Right. Just time for a couple of questions. Yes, please.
Thank you for that. I just wanted to ask you, somebody who has CFS, started with Epstein-Barr virus, been sick for 3.5 years, is there any use in taking the drug Acyclovir?
There have been a number of studies looking at Acyclovir or Acyclovir, and the dosage varies. Acyclovir is actually, in maintenance doses and even high doses, very, very well tolerated. And there's been at least one paper which shows that if you take high levels for at least 6 months, people have got better. But we need very good double-blind, placebo-controlled, randomized trials. I think that's the important thing for all the therapies that have been suggested. Is there any harm? I mean, I not infrequently suggest people with CFS who have these episodes of feeling flu-like recurrently and who have glands in the neck, I do suggest a 6 to 8 week trial of something like Acyclovir and see whether that might reduce some of these symptoms.
Thank you.
Okay. Gentleman up there on the right, yes.
You mentioned the combination of therapies, including targeting the B cells, but also getting rid of any viral infections underneath. So you're mentioning the combination of therapies, yes, including targeting the viruses that were still around. Absolutely. And Dr. Peterson this morning mentioned Valsite and the possibility of the multi-site trial with rituximab, also including Valsite. Is that explicitly connected with that theory?
Oh, absolutely. I'm sure a lot of people are thinking in that way, that you can remove these abnormal B cells. But if one of the factors that have encouraged their formation is a virus with the ability to rescue abnormal types of B cells that have not undergone the correct checkpoint elimination, then you end up with the same problem when the B cells start to regenerate, when the rituximab wears out.
Hi, I'd like to know, I'm trying to work out where I would fit into your theory, because I became poorly many years ago after serious food poisoning where apparently I was at death's door, and you've really been discussing the sort of viral link.
Okay. The gut is the biggest immune organ in the body, and I'm sure you know there are some people who are suggesting that enteroviruses may well be involved. If you have inflammation within the GI tract, then I think almost certainly you disrupt the mechanism of tolerance induction to not only food proteins, but also self-proteins that normally occurs in the GI tract. So I suspect that that initial trauma, as it were, the infection, may have encouraged a temporary loss of tolerance mechanisms, and which then led to the formation. I'm hypothesizing, I'm only conjecturing, but I'm trying to explain on the basis of what you had, that you may then have ended up in a state where you have increased numbers of autoreactive B cells.
So would you still say it was viral and not bacterial, as in the food poisoning itself?
Yeah, food poisoning is very odd. Tell me what bacteria were involved.
I had a really bad case of salmonella with typhoid fever.
Okay. Now, if...
Actually, in the US, and it's interesting when they compare US statistics and symptoms to
look at it in
British.
A different way. Did that infection, the salmonella being intracellular, target the T cells of your system? And if they were disturbed, they would then have a diminished ability to regulate the proper maturation of the B cells. So you could look at it that way. So it need not have been viral in that situation. It could easily have been bacterial, but acting at a later stage in terms of the T cells. Again, I'm conjecturing. We can't prove this.
In our study, we also characterized B cells in CFS patients, and we found a subgroup of patients that showed similar characteristics.
Yes.
I mean, lower percentage of plasmablast cells in periphery, but without a difference in the level of circulating IgGs. And there was a no significant but tempting association between the phenotype of these patients and the drugs that they were taking. Did you control for that in your study?
None of our patients were taking any either prescribed or recreational drugs.
You have the podium.